Good afternoon, everyone. Good afternoon. Please confirm you can hear me.
Good afternoon, Mr. Farouk. Can hear you loud and clear.
I think
Good afternoon, Farouk.
It's a good time for us to start. We're already about 3 minutes behind schedule. Let me at this point welcome everyone to today's webinar, Enhancing Primary Healthcare Delivery via Strategic Governance, Leadership and Management, which is the third in a series of 5 hosted by USAID Integrated Health Program in Nigeria. My name is Farouk Nanobello, and I am a Knowledge Management Manager with the USAID Integrated Health Program in Nigeria. And I'll be quickly going through a few housekeeping items before we get started. If you are at any point unable to hear one of our speakers, please make sure that you have connected your audio using the microphone button on the top right-hand corner of your screen. If you continue to have issues, please add a comment in the chat and one of our contacts will try to assist you. Registered attendees will join the webinar with their cameras and mics off. Please use the chat to introduce yourself, add any comments, or note technical issues. If you would like to come off mute during the question and answer session, please note in the question and answer box and one of our moderators can grant you access to the microphone. We will be using the question and answer function for questions. So if at any point you have questions for one of the speakers, please click on the question and answer button in the Teams control panel box on the right-hand corner and enter your questions there. Please note that this webinar is recorded and the recording will be available immediately after the webinar and sent to your email box if you subscribe ahead of time. It is my pleasure to introduce our moderator for today's session, Dr. Yusuf Suraj, who is the Technical Director for Health System Strengthening, Human Resources for Health, and Sustainability at the Abuja Central Office. Yusuf is a medical doctor with over 10 years experience in development work. He has a master's in public health and business administration. Please make welcome Dr. Yusuf Suraj.
Thank you so much, Mr. Farouk. Good day, everyone. As mentioned, my name is Dr. Yusuf Suraj. And before we begin, I have the pleasure of providing introductions of our distinguished guest speakers. We have with us today Dr. Martha Levitt from IHP, Dr. Siak Al-Hassan, also from IHP. We also have Dr. Aisha Senchi from Kebbi, Mr. Mustafa Prince from Abuja, Dr. Mohamed Jibril from SPCDA in Bauchi, and Mrs. Chinyere Ikwako from IHP. Without further delay, our first speaker is Dr. Martha Levitt. Dr. Martha has spent over 6 years in Nigeria in her current role as the Chief of Party for the USAID Integrated Health Program that focuses on reducing morbidity and mortality of women and children under 5 years of age. Dr. Levitt has a PhD in medical anthropology and a master's in public health in international health and a population studies certificate. And she has 40 years of experience working and residing in and traveling throughout Africa and Asia, designing, implementing, and leading global health projects. Dr. Martha is the founder of the White Ribbon Alliance for Safe Motherhood in India, and she was one of the original designers of the US government Saving Mothers Giving Lives, SMGL initiative, which was implemented in Zambia, Uganda, and Nigeria that reduced maternal mortality rate by 44% in less than 5 years. She will be presenting briefly on health governance, leadership, and management in the delivery of quality primary health care and achieving universal health coverage. Welcome, Martha. Over to you, please.
Thank you. I hope everyone can hear me.
Loud and clear.
Okay, wonderful. Next slide, please. So just to set the scene for this entire webinar, I think that on the left, it'll be very familiar to you. There's 6 systems building blocks that WHO has in the health systems framework. It includes service delivery, health workforce, health information, medical products, vaccines and technologies, financing, and leadership and governance. So this leads to a work that we've been doing is in leading to access, coverage, quality, safety, and strengthened systems for the health outcomes of improved health level and equity, responsiveness, social and financial risk protection, and improved efficiency, which ultimately will contribute to reductions in maternal mortality and under 5 mortality. Please, next. So now, the enabling environment is critical to the achievement of all of those outcomes and goals that we have. In terms of health systems, all of our health systems are to ensure that we are client-centered and that as a client-centered kind of program or initiative for anyone who's working on service improvement, there needs to be a enabling, supportive environment in the community. You're going to hear today about community engagement. Public and private healthcare services are important to provide and access. And then also there'll be local governance that oversees the supervision, also sets some ensures policies are being laid out, and the state government in Nigeria is actually the government that that leads health, and federal government where policies are made and monitored. So if we look on the left side, at every level, you have the need for governance, good planning, all the way from the bottom up. Efficient management, even within health facilities. Service provision needs to start with policies all the way down to actual provision of services and medical products. You cannot have services without medicines. And then on the other side, you can see in terms of health information system information needs to go from bottom up and then from up down so that people can be able to look at their performance, and financing is critical. And at the very, very basis of this is accountability, transparency, and sustainability. Next. So this is my, I think the last part here is using a whole of society approach. You bring together all the multiple stakeholders, you engage them at every single level to have the effects that are needed all the way in the community at health facilities and onwards. So I would actually, we're going to hear from people who are actually have the experience in the field to bring all of this whole framework alive. So I'll hand it back to you, Burke, or should I introduce Dr.?
Yeah, Dr. Suraj, yes.
Okay, Dr. Suraj.
Yeah, thank you so much, Martha, for the presentation and for the wonderful overview of some of the key contributions of IHP towards health system strengthening at the federal and state level over the years. I will be introducing our second speaker in person of Dr. Siaka Al-Hassan. Dr. Siaka is a public health practitioner with over 25 years of experience designing, implementing, monitoring, and evaluating multi-sectoral development plans. He is the IHP Senior Government Relation Director. Previously, Dr. Siaka was the State Director for IHP in Bauchi, and before then, Dr. Siaka was the head UK DFID Northern Nigerian office in Kano. Dr. Siaka received public health training at Columbia University in New York and his medical education from University of Ibadan. Please join me in welcoming Dr. Siaka to take the next presentation on domesticating and translating policy into action to enable the delivery of quality primary health care. Over to you, please.
Thank you very much. Good afternoon, everyone. So I'll take it from where Martha stopped. Nigeria has struggled to improve primary healthcare services at all levels. But in order to address this, a lot of policies have been developed at the federal level that needed to be domesticated at the state level and implemented at the health facility level and local governments. So IHP in the last 6 years has contributed to finalizing and then domesticating policies. More than 75 of those that we have worked on. The idea is to ensure that the policies are finalized at the federal level, it's reviewed properly, and then the SOPs and the guidelines for implementing them are developed jointly, so that once these are ready, we support the advocacies at the various levels to ensure that healthcare providers are familiar with it and they are implementing, and the learnings from implementing these policies are fed back into the federal to ensure that subsequent reviews take care of some of those challenges that may are associated with implementing such policies. Today, I will give specific examples of where IHP has supported such policies and how we have ensured that it's implemented at the state levels where IHP worked. So next slide. So technical implementation of primary healthcare under one roof is one of the areas that I will be talking about today. In this particular area, everybody who is familiar with the systems in Nigeria will know that there has been challenges with management of health facilities because of the complex nature in which the governance of primary healthcare was operating. You had a situation, for instance, where health workers who in the same facility, some were working for the state government, others were working for the local government. Issues of managing promotions and redeployments were so complex. So in order to manage some of these complexities, the government of Nigeria came up with the principle of primary healthcare under one roof, where all of the planning regarding primary healthcare, all of the management, the monitoring and evaluation was brought under one plan. So, and therefore removing those bottlenecks that prevented smooth functionality of primary healthcare. So we focus our energies on providing technical assistance for actualizing this dream by the government of Nigeria. As a result, we paid attention to all of the pillars with which we could measure success of implementation of the primary healthcare under one roof. Next slide. So the plan had 9 specific pillars, ranging from governance all through legislation to human resource and systems development, including managing commodities and all that. So all the pillars are highlighted, and IHP tried to support pillar by pillar to ensure that this policy was brought to fruition. An example is in the governance and ownership space. IHP supported the various coordination mechanisms, including the technical working groups and the SEMCHIC and LEMCHIC, which are operational arms of monitoring maternal health and child health and dealing with emergencies as well, coordinating between the primary healthcare development agencies and the respective local governments, to ensure that issues are identified commonly and solutions are found to it. So ensuring that those coordination mechanisms are functional was one of the ways we work with it. And we also ensured that we work to remove all legislative bottlenecks that could get in the way of implementing primary healthcare under one roof. Another area where we had to work in a multi-stakeholder approach is ensuring that the minimum service package investment plan was developed and implemented. This helps us to identify what were the gaps that were mitigating against providing adequate primary health care to all of the population. So using the population distribution, availability of services, and the availability of the human resource to do that, we came up with a plan that for each of those states determines how many facilities are actually needed, how many health workers will be required to deliver those services, and then identify where we are now and where we need to be. And those gaps became the advocacy tool to all of the stakeholders to ensure that we're able to move on getting primary health care to be delivered across all of the states in Nigeria. Next slide. So the human resources was one of the biggest areas that we needed to work on. First, there were not adequate number of health workers, and then we didn't have the adequate cadre of health workers, and they didn't have the requisite skills. So IHP worked on all of those. One, advocating for a recruitment of more health workers in all of the affected states, and then redistributing existing workforce to be more equitable. Many of the health workers were concentrated in state capital and a few urban local government headquarters. So to ensure that the more rural health facilities had adequate human resource to deliver the minimum service package that required multi-stakeholder efforts, to ensure that this took place. Even the funding from the Basic Healthcare Provision Fund, we ensured that part of it dedicated to human resource was actually applied, to providing human resource to bridge those gaps. But once the human resource was in place, we used our novel approach to build their capacity to ensure that they are able to do a whole lot more. And the next policy that I will talk about will also address how we used it to ensure that human resource did the best it could in the situation that we found ourselves. So next slide. So the next part of the policy that I was going to talk about is the tax shifting, tax sharing policy. Like I mentioned earlier on, the human resource for health was inadequate, and the available human resource didn't have the requisite skills to be able to provide the full-scale minimum service package for all of the people. So to address that, we work with government to finalize the tax shifting, tax sharing policy, which allowed health workers of different cadre to be able to do a whole lot more than they were originally envisaged to do. What that did is that we have community health extension workers, for instance, now being trained to manage more complex areas in maternal health, family planning, and child health. Before this support, community health extension workers, for instance, were not allowed to go into areas of long-acting reversible contraceptive implant, for instance. However, as a result of this intervention, they're able to do that. So that resulted in more health facilities being able to provide wider range of services and more personnel available to provide those services. So the objective of this was to optimize available healthcare resources, for accessing essential services. So we domesticated the policies, we disseminated and trained the health workers available. So that led to an 80% increase in the availability of skilled vet attendants in the facilities that we supported. And that was a huge leap. And this is something that the government of Nigeria has learned from, and they're trying to replicate it through the training of 120,000 frontline health workers, which is something that is applauded. So thank you very much, everyone, for listening. I'll go back to you, Yusuf.
Thank you so much, Dr. Siaka. Farouk, can you please reshare the screen because it appears to be down? So thank you once again, Dr. Siaka, for the wonderful presentation on some of the key policies IHP have been able to work with the federal and state government to implement towards improving the health system in the country. Our next presenter is Dr. Aisha Senchi. Dr. Aisha has over 7 years of experience in health system strengthening, including key elements such as health policy and financing, leadership and governance, human resource for health, with over 20 years of experience in development work. She is a community and social mobilization expert with focus on both pre-service and in-service training support. She is presently a Deputy Director, Medical Lab Scientist, with a Master's in Public Health and a PhD in Health Planning and Management. She actively engaged in the development, government, and non-governmental organization work. She has worked on several projects in varying capacity and was instrumental in the establishment and operationalization of the State Contributory Health Insurance Agency in Kebbi State. She will be presenting on community engagement in health governance, some experiences from a community in Kebbi State. Dr. Aisha, over to you, please.
Good evening, everyone, and thank you, Dr. Isiaka, for taking us through how domesticating and translating policy into action enhances the delivery of quality primary health care. And now I will be speaking on community engagement in health governance and lessons learned from communities in Kebbi State, Nigeria. Community engagement is an approach to address health-related issues, promoting well-being, and taking action on the social determinant of health. It actually involves building relationships based on trust and working together to develop more effective health interventions, programs, services, and policies, and empowers communities as key actors to their health. Some of the benefit of it is that it promotes behavioral change, positive health impact, inclusivity, and transparency. Next slide, please. Next slide. Effective community engagement provides supportive leadership. It enables citizen participation in decision-making. It also invests in their skills and create a quick and tangible win to build trust. Next slide. Community leadership engagement enhances healthcare utilization and contributes to better health outcomes. For example, in early disease detection, management of chronic diseases, health education, and patient satisfaction. So armed with findings and recommendations from political economy assessment conducted by IHP in Kebbi State, we were able to identify, categorize, and map out our stakeholders based on those with high influence and high interest. And we also identify our major players as follows. IHP realized that His Excellency is a key player, and all the 4 emirs, the religious leaders, top government officials, top political office holders, legislators, senators, philanthropists, and the private sector. So armed with that, IHP engaged these stakeholders at different levels. The first of which was to revive the legislative network on universal health coverage so as to fast track the operationalization of the Kebbi State Contributory Healthcare Scheme. The head of service, who is critical in deployment of management staff, and the governing board was also a critical stakeholder we worked closely with to ensure that happened. IHP engaged His Excellency, the Governor of Kebbi State, to approve the participation of formal sector into the health insurance scheme. The religious and traditional leaders to understand the benefit of the scheme and mobilize members to participate. The private sector organized unions such as NURTW, that is Nigerian Union of Road Transport Workers, Fish Sellers Association, and also other implementing partners. So to achieve this, IHP identified and leveraged on the existing structures, for example, the WDCs and other community structures. So those structures were revived and strengthened, support the conduct of multi-level sensitization and orientation to create awareness in the benefit of the scheme. IHP conducted high-powered advocacy, supported private and informal sector engagement, engaged beneficiaries at every level to tell their stories on the benefit of the health insurance scheme, and also established media network on universal health coverage to market the scheme using local dialect. Next slide, please. Next, okay. So some of our key achievements include enrollment of over 135 lives from zero to over 135 lives throughout the life of the project, and also as a result of the strategic intervention. Then participation of the states and local government civil service into the health insurance scheme, payment of premium for 500 vulnerable in fulfillment of an advocacy visit to a senator. This happens even after the life of the project. Other achievement includes the district head of Godangwaji district mobilized the informal sector, about 600 in 2021, 720 in 2022, and 1,260 in 2023 to participate in the state health scheme. 7 primary healthcare centers were adopted and fully revitalized in Birnin Kebbi local government by communities. a philanthropist constructing a fully furnished maternity and family planning ward, completed fencing, and solar motorized borehole in Zulu local government. It becomes so competitive among the emirs that they mobilize their communities, the emirs of Gwandu, Argungu, and Zulu, and adopt over 4,000 beneficiaries, most of whom are vulnerables across the three emirates. While the emir of Yauri mobilized a philanthropist to pay health insurance premiums for 3,000 beneficiaries over a period of 3 years. Next slide, please. So IHP sustainability and legacy leave this recommendation to the states so as to increase participation into the state health insurance scheme by both sectors, that is the formal, informal, and also the continuation of adopt PHC and adopt a family initiative. So some of these recommendations are decentralizing the health insurance scheme by the by the agencies to move closer to communities, either to the emirate councils or to each of the local government headquarters. Establishment of the universal health coverage champions at grassroots level, engaging the WDCs during supportive supervision and mentoring visits to highlight some of the key areas that there are challenges and how best they can help in addressing those challenges. To also explore the use of mobile POS vendors to ease payment of insurance premiums, and also organize quarterly and annual meetings with communities to discuss successes and challenges. So now you'll be listening to the next presenter who will take us through health governance experience from the World Development Committee. Thank you.
Thank you so much, Dr. Aisha, for your insightful presentation. You have been able to share some strategies of community engagement in Kebbi, which led to the enrollment of so many lives into health insurance scheme, which is actually a step towards achieving universal health coverage. Thank you so much once again. Our fourth speaker is Mr. Mustafa Prince. He is the World Development Committee chairperson of Lugbe in FCT, and he holds a diploma in electrical engineering. He had worked as a social worker where he engaged in a series of community services. He's currently a general contractor and a farmer. He will be presenting on community engagement in health governance, experiences from the World Development Committee in FCT. Welcome, Mr. Prince. Over to you.
Thank you. Community engagement in health governance experiences from the World Development Committee, WDC, in FCT. Thank you. Leadership and governance. Leadership is the ability to influence other members of an organization or community to actualize a set goal. Yes, we all know that there is need for leadership, especially in providing quality health care at the community level. So World Development Committee goal, the effective provision of healthcare services in Lugbe Primary Healthcare Center in Abuja Municipal Area Council, Nigeria. WGC as a link with the community and the primary healthcare facility. Without members of the community, there will be no functional primary health care. WDC, that's World Development Committee Service, serves as the link between the PAC and the community. Strengthening the link, this link is key towards the effective service delivery in Lugbe, not just in Lugbe alone, but in all our primary healthcare facilities. The role of WDC in community engagement and support of primary health care. Responsibilities of WDC. Primarily, we are so much engaged in so many areas, but we narrow it down, providing general oversight functions on facility and financial management of the primary health care for effective healthcare service delivery. Serve as a mediator in conflict resolution between community members and the PAC staff management. Provide physical and financial support to the facility to ensure smooth service delivery in the primary health care. Our influence, the WDC influence in primary health care service is so important that we, because of time, I cannot really speak much on it, but just to mention a few. Highly influential in resource mobilization and ensuring judicious utilization of primary health care's resources. For instance, we ensure that whatsoever comes to the primary health care, both consumables, cash, drugs, we police, we monitor the judicious use of those items. So WDC, World Development Committee, uses its influence and connections in addressing misconceptions and promote maternal and child and other service delivery uptake to the community members. Just recently, well, I believe this one is still very fresh, COVID-19. Our community members have a different impression about COVID-19. Not until, as a WDC, we went into our immediate communities, we demonstrated it by taking the vaccine. People see us, that some were saying, okay, after 3 months, if some of us did not die before they will go for it. And because they see us doing it, so they were convinced. These are some of the misconceptions we're able to erase. Ensure acceptance and promotion of the services provided by the staff of the PAC. Yes, next please. These are proven strategies which WDC has been positively engaged. Open communications, using WhatsApp platforms and conducting periodic monthly meetings, establishing a supervisory plans for all WDC members for regular visits and monitoring of facilities activities, enabling problem-solving sections. Yes, there are times that there are issues that cannot wait until our next meeting for the next month comes up. So if as problems comes up, we have to wake up to the task, ensure that we meet urgent emergency meeting to address whether some, for instance, in Lugbe PAC, just recently, there was an incident that they rushed an accident victim to the facility, and because we don't have the primary care, is primary, they do not have such power or equipment to address the accident victim. They were immediately given a referral, but the victim, the patient was very annoyed, and the family that brought in, honestly, they broke some of our windows. So not until we were called upon, the moment I came to the facility, oh, no, it's like this. So these are some of our responsibilities that because of time, we cannot really explain. Result from engaging the WDC since inception, IHP ensured effective community engagement through the creation and support of World Development Committees for Lugbe, not just for Lugbe PAC. AMAC, we have 12 wards, and all the wards have the WDC. In Kabusa ward alone, where Lugbe PAC is located, we have functional PACs in other Kabusa ward alone. So you can imagine the whole of AMAC, I have 64 functional PACs. So not just only in Lugbe, but we will narrow it down to a particular PAC so that you can understand what we are saying. Key result: improve governance at the facility level, mobilize over 5 million naira and used to renovate the facility. If you go to Lugbe facility, I'm just saying Lugbe, you can equally visit Kuchingoro. You see that at times the inflow of patients and clients, you will be wondering whether it's a secondary facility, but it's PAC. So we cannot leave everything for the government. The government will do it. We just have to, as WDC, to, in our little way, we influence the people that we know within our community, enhanced uptake of service delivery, including routine immunization services, antenatal care, attendance, and facility-based labor and delivery. So, next, please. Conclusion. Ward Development Committee are very important in improving primary health care service delivery, because we are the gates between the community, the PAC, and even the government. So because the people in the community really believe so much in World Development Committee, it is very, very important to work closely with the World Development Committee to achieve improved access to quality integrated healthcare services. Thank you. Next. Sorry, I'm done. Yeah, thank you very much.
Yeah, thank you so much, Mr. Prince, for the succinct presentation. You have actually been able to share some vital support of the World Development Committee using Lube as an example and how they were able to raise funds to innovate and improve healthcare in their community. That is quite impressive. Our fifth presenter is Dr. Muhammad Jibril. He is the Director of Planning Research and Statistics in Bauchi State Primary Healthcare Development Agency, who will also be presenting on the coordination for harmonized health system planning using the annual operational plans. Dr. Jibril is a medical doctor and a professional field epidemiologist with over 30 years working experience in public health, especially in areas of disease control, immunization, maternal and child health program planning, and implementation. Welcome, Dr. Jibril. Over to you, please.
Good evening, everyone. Let me start by appreciating Mr. Prince for a wonderful presentation on the roles of WDC in our health facilities. So I'll be talking about the coordination for harmonized system planning using annual operational plan. Next slide. So as the popular adage, failure to plan meaning planning, somebody is planning to fail. So health planning represents first step in an orderly process to accomplish the things necessary to improve the health status of individuals and population. So without any plan, we will not be able to achieve the desirable intervention that we need to improve the health and living standard of our population. So the community guide of the US.gov defines public health planning as a multi-step process that generally begins with the definition of the problem and development and evaluation plan. Next. So next slide. So what are the benefits? If we have a coordinated plan in the health sector, there will be an improvement in efficiency and resource optimization, which will prevent duplication of effort, duplication of resources, and also it will enhance the type of and the quality of the service that is being delivered. It also gives room for transparency because the plan will be available for all stakeholders, everyone can see, and will also improve in the institutionalization of the accountability framework. Next slide. So the significance of the annual operational plan, prior to the support from the IHP, the states normally have vertical plans. We used to have plans for immunizations, plan for nutrition, and plan for all sorts of services being supported by different partners. But being integrated focus, the USAID IHP supported the state, and the significance that we are seeing is the issue of the sense of direction that is given to everyone, and it is the achievement of the organizational goals, and also provides avenue for the implementation of the long-term strategic plan. We have the long-term health system strategic plan, which is normally a 5-year plan, but normally it is just there being archived. Nobody is even looking at it. But with the coming of this support from the IHP, all stakeholders refer to it and develop annual operational plans. Next slide. So in Bauchi State, the annual operational plan development consists of so many stages. As mentioned earlier, we refer to the state strategic plan, and also we look at our own achievements and challenges from previous plans, and also look at the routine data platform, the district health information system, the integrated disease surveillance and response system, the national health management information system. All this data we analyze and look at to see where we need to focus during the year. We also look at the bottleneck analysis and also look at the quarterly scorecard that we are developing to make sure that we make improvements in the indices where the state is at the lower side. And also we used to look at our mirror is the national surveys, the national demographic health surveys, the national immunization coverage survey, the multiple indicator cluster survey. This we use them as a benchmark, as a baseline to monitor and improve our indices. We also look at the emergencies of public health importance, like the issue of the COVID. When the COVID comes, we even need to review the plan and the budget allocation. We also look at the implementation partners. Prior to the support from the IHP, every partner is on his own, having a different plan. But courtesy of that, we have a harmonized plan, which normally begin the planning process and development process, where it starts from the community to the health facility to the LGA, down to the state, and finally is being endorsed by what we have as the high-level committee, the state task force on primary health care, headed by the deputy governor. Next slide. So as I was saying, these are the pictorials. You can see in this picture where stakeholders sat down, looking at all the parameters that I had mentioned, and they are developing the 2024 annual operational plan. So here, the next picture is showing His Excellency, the Deputy Governor. You look at the traditional leaders who are represented, the first-class emirs, receiving reports of the performance of the work plan, as well as the PAC MOU milestones. So lastly, this is the stage of the endorsement. You can see at the first picture, the Deputy Governor is endorsing, and by that, you can see that it is now a working document for everyone, every partner, every program officer. All the partners are represented. You can see them on the picture. So the process, the operationalization of this starts with the development of a monthly plan. You can see the series. We start from the strategic plan to develop the annual operational plan. Then we develop the monthly plan. Then program officers asked to write proposal and request for funding and support it. And later they report and retire. And also on a weekly basis, we look at the implementation of the monthly plans and the quarterly analysis of plan versus conduct. And we also look at the finances, and through the recommendation and foresight from the IHP, we established what we call the AP tracking committee, which are helping to facilitate all this process. Next slide. So there are so many accountability framework in place for the finances. We normally request on quarterly basis for no objection. This no objection request is being sent to all the MOE partners, USAID inclusive, the BMGF, the Ali Kotongote Foundation, where they look at what we propose to do for that quarter, and all grant their own approval, and they may ask questions where necessary. And funds are being disbursed on quarterly basis using electronic means to avoid any cash transfers that will bring about leakages. Likewise, we also have some other stringent accountability framework where we have the monthly financial validation, monthly financial spot check, and also quarterly financial meeting with the local government accountants. We also have the internal auditing system, and also we employ the services of an independent external auditing firm on a yearly basis to audit the accounts. Next slide. So what are the lessons learned? Actually, initially, what we used to do before the support from IHP, we normally develop the work plan at the state level, then we descend it down to the LGHAs and health facilities. And for this new approach, starting from the bottom, we've seen a lot of development, a lot of ownership, and the tracking committee are also performing. And likewise, also the oversight function of the state tax force on primary health care also resulted in strengthening the accountability framework. Implementation of the multilateral MOU also resulted in reducing dependency in funding for the area development, where the state has been asked to develop sustainable plan and which is being implemented. Next slide. So the achievements so far recorded with the availability of one plan and one monitoring system, the good coordination, also the resource being optimized, the integrated and qualitative services being rendered, improved financial accountability, and the overall improvement in the health indices of the state. Next slide. So this is our recommendation whenever we are doing, and for everybody that is doing any annual operation plan, we should look at the situation analysis, try to identify and prioritize the problems, also set some objectives, have strategic formulation, and we need to sequence the activities, and with appropriate timeline, and we need to allocate resources with clear funding sources. And we need to have a robust monitoring and evaluation framework. Next. Thank you for your time.
Thank you so much, Dr. Jibril, for your wonderful presentation. Indeed, the importance of the annual operational plans cannot be overemphasized. You have actually been able to elaborate how IHP worked closely with multiple stakeholders to achieve a more efficient and strategic annual operational plan in the state. Our last presenter for the day is Mrs. Chinyere Kwako. She's currently the Leadership and Governance Advisor for USAID IHP in Ebonyi. And prior to USAID IHP, Mrs. Chinyere worked with USAID Health Policy Plus as the Social Accountability Advisor, and with DFID, now the FCDO, as the Voice and Accountability Specialist under the Partnership for Transforming Health System Project. That's the Part 2. She has over 10 years working experience with significant experience in health system strengthening. Chinyere's expertise spans across health governance, capacity building, stakeholders engagement, health policy, and citizen engagement. She holds a master in public health and certifications in leadership and management in health, project management, health policy and health system, as well as advocacy and citizen engagement. She will be presenting on the USAID State PHC MOU dashboard, lessons from tracking political, technical, and financial commitment. Over to you, Mrs. Chinyere.
Thank you so much, Dr. Suraj. Hello, everyone. So in the next 7 to 10 minutes, I'll be taking you through these presentations themed USAID State MOU dashboards, lessons from tracking political, technical, and financial commitments. The PSC MOU grew out of the original routine immunization MOUs practiced in Sokoto and Bauchi State. But in 2019, USAID expanded its MOU to strengthen and revitalize integrated primary health care. There are two clear objectives for the state and USAID to achieve the MOU. One is to increase the coverage of states' minimum service package for primary health care, and two, to improve the capacity of states to plan, allocate, and manage resources. Two types of MOU were practiced across the 5 IHP-supported states. One is the bilateral MOU, which is the MOU between the states and USAID, and this was practiced in KB, FCT, and Ebonyi State. And also the multilateral MOU that is between the states, USAID, and donors, and this was also practiced in Bauchi and Sokoto State. The MOU has 5 milestones that are derived from the State Strategic Development Plan 2. Next slide, please. This is a picture representing the 5 strategic pillars and the 15 priority areas. As you can see, some of the priority strategic pillars have more than one priority area. Next slide, please. Next slide, please. In the MOU, there was provision for MOU leadership and governance. IHP supported the state in the establishment and inauguration of the Steering Committee and Operation Committee. These committees are multi-sectoral. For the Steering Committee, they are saddled with the responsibility to conduct regular oversight of the implementation of the MOU activities. For Ebonyi State, this committee is chaired by Commissioner for Health, and also serve as a venue to promote transparency.
Also for the operations committee that started with the responsibility of regular planning and oversight of MOU activities. They track targets quarterly using the indicator dashboard. And this committee is chaired by the Permanent Secretary, State Ministry of Health, and co-chaired by the Permanent Secretary, Ministry of Grants and Donor. Next slide, please. To measure the performance of the state in achieving the MOU milestones and indicators, an MOU dashboard was introduced. This MOU dashboard is a data visualization tool that visually tracks, analyzes, and displays at a glance the performance of the 5 strategic pillars. It also shows the aggregate performance of all the strategic pillars. As you can see on that slide, 57.2% is the aggregate performance for Ebonyi within a period. It also tracks and shows the commitment of the steering committee as well as the operations committee. Next slide, please. This dashboard has 2 major components: the data entry sheet, which is the back end, and also the visual analysis, which is the front end. The back end is where tracking information is entered. It is structured according to 5 strategic pillars. Information entry fields have been provided for all review periods from the beginning to the end of the MOU lifespan. Also, data is entered in this back end as 1, 2, 3, or 4, and it is color coded. 1 means red, 2 and meaning that there's no progress, 2 is yellow, meaning that there's progress, 3 is amber, meaning that the state has met 75% of its target, and 4, green, meaning that the target has been met. So for the front end, which is the next picture, is the visual display of the metrics of all the 5 strategic pillars. I've explained this picture when I was explaining the dashboard. Next slide, please. After development of the dashboard, a guide was developed and the operations committee was oriented. IHP and other USAID IPs, notably Health Workforce Management and Presidential Malaria Initiative for States, Global Health Supply Chain Procurement and Supply Management, and Breakthrough Action for Nigeria, supported the state to update the dashboard every quarter. Next slide, please. Remember that at the entry sheet of the dashboard, which is the back end, the data is entered 1, 2, or 3. To determine whether an indicator is called 1, 2, 3, or 4, there are criteria for that. Let me cite an example using one priority area and an indicator. Under leadership and governance, and looking at an indicator, number of words will revitalize PACs. To score this indicator using criteria, the state is scored 1 if they have revitalized less than 30 PACs, 2 if they are revitalized between 60 to 31 to 60 PACs. So depending on the state performance, the indicator is scored. Next slide, please. The dashboard has proven to improve transparency, accountability, and decision making. At the end of every operation committee meeting or steering committee meeting, action points are raised from the presentation that the state made and action plan developed. These action points ginger the government to improve on their performance. I will make reference to some of the indicators where the state has improved due to advice from these meetings. One of the indicators says number of PACs implementing functional DRF. Here, the state has been underperforming because the state did not have drug management agency in place. As this continues to come up, the State Ministry of Health took action to develop a bill, review the bill, and present before the former governor. But this did not see the light of the day. But when the new governor came on board, the State Ministry of Health represented this bill before the new state governor, and the bill got signed, and the Drug Management Agency got established with an executive secretary appointed. Now the state has kickstarted implementation of drug revolving fund. The second example is there's an indicator that talks on financial risk protection as it concerns formal sector enrollment. The State Health Insurance Agency has not been performing well on this. So during this meeting, they were advised to meet with the new governor and present this case and convince him on the need to enroll the civil servants. Today, the formal sector enrollment has been flagged up, and about 8,000 civil servants have been enrolled and are serving services. The next example also is on the timeliness of harmonized annual operational plan. Before the MOU, the state's SMOA developed annual operational plan fragmentally. Each department develops their AOP without considering the state budget cycle. But with the MOU, the state is held accountable to ensure that the harmonized annual operational plan is finalized by the end of third quarter of the year and incorporated into the state budget. Next slide, please. Key lessons learned. Lessons were learned. One of the lessons learned is during the implementation of the MOU, it was noticed that some of the targets were unachievable. So there was discussion with USAID to review this target, which was agreed. So the state reviewed the target to be more realistic and more achievable. Also, poor budgetary allocation to health and release has also become a challenge in the implementation of the MOU. The Basic Health Provision Fund and World Bank impact projects act as buffer to help in the implementation of the MOU activities. So the state is performing well in some of the primary healthcare activities. And also the MOU has been seen to serve as an accountability tool, making the government to take ownership of the indicator performance. Next slide, please. Recommendations. There is need to add other partners to bilateral MOUs, as this will ensure better performance of the MOU. And also, the IP's work plan should be seen as playing complementary role to the states in achieving their MOUs. And also, the dashboards should be updated quarterly and shared among partners to discuss how to improve the results. Thank you so much.
All right, thank you so much for the wonderful presentation, Ms. Chinyere, and for the insight on the support IHP provided towards the operationalization of the MOU and some of the outcomes and achievements linked to routine tracking using the dashboards. Finally, we'll take a question and answer and comment session, and this will be handled by Mr. Farouk Bello Nano. Thank you so much, everyone. Farouk, over to you, please.
Thank you very much, Dr. Suraj. And thank you to all the presenters for a wonderful presentation. Well, some of the questions are actually in the chat box, but of course, I have an intel of people who also have questions to ask. I think it's better we just make it okay. Let me start with some of the questions I have here. I don't know, any of the presenters can actually handle it. If you think you have answers to some of these ones. The first one says, how can facility-based healthcare workers effectively engage with stakeholders like state entities, LGHAs, and WDCs to drive positive changes in healthcare delivery within their communities? So I don't know who will be responding to this. Okay, so let me take it again. Mr. Prince will want to attend. How can facility-based healthcare workers effectively engage with stakeholders like state entities, LGHAs, and WDCs to drive positive changes in healthcare delivery within their communities.
Okay, thank you. Can I go?
Please go ahead.
Okay. What development committee of giving the enabling environment, because the staff of PACs are equally part of the responsibility of the World Development Committee to see the activities and also look at their welfare. So the issue of payment, I think most of our primary health care centers, there are a lot of volunteers. Most of the staff there are volunteers, and it is the primary health care facilities themselves that are paying them from the little something they make. So that's the best I could attempt, sir.
Okay, thank you very much. Okay.
Yeah, so thank you so much, Mr. Clark. And I'd like to just add a few words to that. So the frontline health workers have multiple gateways through which they can engage with government as well as communities. So one of them is, we mentioned platforms that exist at the local government and at facility level, including facility management committees that has representation from both community and government side. We have the centric platforms that allow them to escalate issues, towards a higher level, local government and at the state. In addition, there are quarterly integrated supportive supervision that brings senior government officials at state level and local government to interact with health facilities. And that opportunity can be used to address issues that bother health workers at the health facility levels, as well as those at the local government. So I think every opportunity they have with these platforms can be a potential avenue to escalate the issues that affect their operations, whether as individuals or as facilities. So, in addition to other more established, formal avenues for escalating issues and reporting incidences and affairs. But I think facilities do have those kinds of opportunities to interact and engage with authorities at local and state government. Thank you.
Thank you very much, Dr. Siaka, for adding more light. We have another one in the chat box, and this is from Adamu Yusuf. Thank you, Adamu, for being part of this interesting exercise. And Adamu says he thanked the presenters and he appreciates the tangible impact of data visualization, the significant progress made in establishing the State Drug Management Agency and the harmonized memorandum of understanding. However, he has a concern. What role or space is allocated for civil society organizations within the MOU? Did you get the question?
Okay.
Yes.
Okay. Yeah, okay, thank you so much. The civil society organizations are members of the MOU steering committee. And of course, we all know the roles of the civil society organizations as accountability mechanisms. Some of the issues raised during the discussions, they carried forward to government and advocate for improvement. For example, they have been advocating for increase in budget allocation and also budget allocation for primary health care. So some of the issues that will improve the MOU, they push that with the state, with the committees. Thank you so much.
Thank you, Chinyere, for that. We have another participant who wishes to speak, whose hands are up, Jamilu Yunusa. Jamilu, you can please unmute and speak. Jamilu Yunusa, are you there?
Okay, I'm there. Thank you.
Thank you.
Good afternoon, everyone. And that's a wonderful presentation from all the presenters, and I commend all of them for a nice job. One of the ways I I suggest, or I am thinking of improving our healthcare delivery, or let me say furthermore, to continue increasing our healthcare delivery in our various states is community engagement. Just as the presenter had just said, we need to focus on our WDCs and our civil society partners in the state, and also the local government chairman. These three people, they are the key people that can help in contributing in enhancing our healthcare delivery, because helping a community without their consent or without their involvement is just like a waste of time. So I believe bringing these three people together by international organization or working with them, which means the civil society, the WDC, and the local government chairman of that community or of that ward should be involved in any process that has been taken into, because it tends to ease the suffering, or it tends to help in delivering a good service to the primary healthcare in various communities, because I suggest that we can do much more with them, because it's not something that we can do alone as civil society alone, but bringing them together, learning from their advice and implementing such activities suggested by these people will go a long way to foster progress and more impact in that community. So I would suggest if IHP could focus more, or should penetrate more in working with these three people in each local government of the various states to make sure our primary healthcare delivery is more functional than before. So thank you.
Thank you, Jamilu Nisa, for that. Okay. Okay, so we'll take the next question there. This one goes to Ms. Chinyere from the chat there. What are the steps taken to review annual targets? What is the criteria for the review of these annual targets, and who, where, or who can be involved?
Sorry, can you come again? I didn't get some of your statement.
What are the steps taken to review annual targets? What is the criteria for the review of these annual targets, and who, where, or can be involved?
Okay, to review the annual targets, we have the implementing partners and the committees. They review this using the dashboard, and the criteria for reviewing these, I think I mentioned that in one of my slides. There are criteria for measuring each indicator, and also there's also means of verification for any target or any point that the state claims. So we have our criteria, which I presented in one of the slides, and also the IPs as well as the committees gathered to review the targets.
Thank you, Ms. Chinyere, for that response. And quickly, let's take another one. This is coming from Peter Osaji. It says, harnessing and amplifying patients' voices on their experience of care is a crucial component of community engagement for patient-centered interventions. How was USAID IHP able to get the voices of the users of healthcare services to improve quality delivery at the PHCs? Okay, Dr. Siaka wants to respond. Please go ahead.
All right, thank you very much. I think we explored multiple ways of getting user voices, for accountability purposes. One of those is the accountability hotlines that IHP supported. These are toll-free telephone lines that clients are able to provide feedback, whether positive or negative, and with specific mentions of facilities they visited, what their experiences were, what issues they had that they want to bring to our attention, whether it's positive or negative. And we, in turn, created a systematic way of providing this feedback, to the CERIC, SEMCHIC sessions in the state, where those who are concerned, who are responsible for all of those interventions are able to follow on to say what has happened, which facility, which client was involved, what was the campaign, and they're able to trace that. And as part of our transition out of the state that was supported, these platforms were transited, including the back ends to the state. So they're able to monitor that platform to continuously get feedback. Another way is the use of WDC. Like we said, facilities have those representation from the communities, and we embarked on a lot of sensitization to ensure that communities are aware of who their representatives are on the WDC, and therefore are able to bring issues and feedbacks to WDC members, whether it's positive or negative as well, to let them know what is happening at the health facilities, what interventions are required, and what needs to be done. And WDC will mediate between the facility, the clients, and the government, including partners, as the case may be. So these avenues are there for users to exploit, and the various community engagement activities are also other avenues through which clients can come up with their experiences and what government or the facility could do to address some of the concerns. Thank you.
Thank you, Dr. Siaka. And quickly, let me take this one. It's also very important, and this is targeted at Mr. Mustafa Breeds. This one says, how do WDC manage political interference from public office holders, especially as regards facility financial management?
Thank you. World Development Committee is non-political. We are not politicians. So we don't belong to any political party. We are not partitions. So we are selected from various communities that made up that ward, political ward. For the fact that we are representing a political ward doesn't make us a partitions. So, and our political leaders, although in every ward, all the councillors are automatic members of World Development Committee of their ward, but they are just members. They have no any power. And because we have, WDC have a guideline, who become this and how do you become? For instance, myself, I was elected, and only the WDC's members that have the right to vote. So there's no interference at all.
Thank you, Mr. Prince, for that. Well, let me just quickly read out this from Lovett Chukura from Iboi, who said she is very impressed with the presentation by the WDC chairman. And that goes to show that IHP has really empowered him. Well, thank you, Lovett, for that. Quickly, another question is, any compensation? This is coming from Flores Reynaldo from El Salvador. We're so excited to have you join us. And the question is, any compensation for voluntary workers?
Well, volunteer workers in health facilities are paid what they call stipends. Usually small amounts of money are paid from user fees collected from health facilities to these sets of workers, but not commensurate with the salary or minimum wage of the state. So there are ongoing advocacy efforts, to ensure that state governments absorb these volunteers to become full-time workers, so they become eligible to earn the minimum wage as stipulated by the government of Nigeria, and then using other mechanisms such as the basic healthcare provision funds to prioritize volunteers when recruiting, so that they become full staff. But at the moment, stipends are paid, but it's inadequate and it's below the par for what workers with their qualification and experience are expected to earn.
Thank you very much. There's another question, which I think is also very important. This one says, Nigeria has a ton of policies written and stored in shelves. What are some practical strategies for translating these policies to actual practice in states without specific technical support in governance like IHP?
Well, I guess some of the efforts that IHP has been embarking on in the last few months to try to institutionalize of the intervention as practical steps to addressing this. First of all, who should be responsible at the state levels for tracking what policies have been developed at the federal, what would it take to implement them at the state level, how would you monitor and evaluate the implementation, how would the feedback loop get to the federal to review whenever necessary. These are some of the engagements we've been leading over the last few months, especially with the departments for planning, research, and statistics of the states that appear to be statutorily responsible for some of these, warehousing some of these policies. Other issues which have been maybe serious is issues around funding. So a lot of policies are developed, but not enough funding mechanism to ensure that they are implemented. And that's why we've also expanded the horizon for funding healthcare, including developing a private sector investment strategy to drag or draw on resources elsewhere, strengthen the coordination mechanism between partners to leverage more and optimize the resources that are already available through those partnerships and so on. That way, policies to practice become a little easier if the funding mechanism is in place. I know we also have programs that are funded by some USAID, others through UK Aid that are working on corporate strategies, helping institutions of government to understand their core mandate. That allows them to realize what their roles would be in policy formulation and policy implementation. Some of the gaps that we've seen in the past is policies are just hanging there in the air and the government entities are not sure who is responsible for what. So these corporate planning interventions that the governance programs have been spearheading have been ways in which we try to address that gap, creating the clarity around that and everybody understanding what their roles would be in policy implementation and so on. But it's a long road, and but we think the journey has begun, and that's why we give specifics about some policies that we have worked on, all the way to implementation. And I think Marta want to say a few more.
Okay, Marta wants to speak. Yeah, so because of time constraint, I think that's the much questions we can take. So just allow Marta to speak and then, yeah.
I think with any policy development, we have to think of sustainability from day one. It's not an afterthought. Is it an affordable strategy or policy? Can it be implemented in the current situation? What will it take? So sustainability can never be an afterthought. Of course, sustainability is a long-term. It depends on where for example, some states have very low indicator thresholds, whereas others are quite high. They will have very different abilities to be able to improve health. So we had a couple of states that had very low indicators, and we were able to really work with them to implement these policies and bring their indicators up. And I think once you're working with states that have fairly high indicators, making an impact is going to be a little more difficult. But I think that the policies do have to be very practical, and they're implementable, they're affordable, and they are going to have an impact. Thank you very much.
Thank you, Marta, for adding your voice to that interesting topic. So like I said, because of time constraints, that's the much we can take from the questions we have. And let me go back to Dr. Yusuf Suraj, the moderator, before we wrap it up completely. Dr. Suraj.
Thank you so much, Mr. Farouk, and thank you so much to all the presenters and for all the questions as well. I think we have spent our time, and we really do appreciate all of the participants from the external people, including those from IHP as well. We really do appreciate everybody that has actually been able to join. So I think Farouk can take the acknowledgements, and then we just wrap this up. Thank you so much once again, everyone.
All right. Thank you very much, Dr. Suraj. Just to re-echo what you said, I want to, on behalf of USID IHP, thank each and every one of you for making our time to be part of this knowledge sharing activity. Indeed, we are honored. I'm happy particularly to know that people have joined from far and near. Like I read earlier, somebody from El Salvador, Flores, also joined. We have people who have joined from many African countries, from the Europe and all. Thank you. We also have some IPs, who have also joined this very important exercise. And we thank the IHP staff as well for being a part of it. And we look forward to having you on board our next series of webinar. Please be on the lookout because it is coming soon and it's going to be another interesting conversation that we'll be having soon. Thank you so much. And don't forget to join our social media platform at Nigeria IHP on Facebook, Instagram, X, and of course on WhatsApp. Thank you very much.
Thank you all.
Thank you. Thank you for joining. We appreciate you.
Thank you so much, everyone. Have a wonderful day.
That was so beyond my expectations.